Uh, Thank you, Chair, person, and convey my thanks for your kind words. It's my proud privilege to be here to share my knowledge. I would be discussing a little different. When we treat diversity, we talk of beta cell. So can we move from beta cell to brain? And we have already moved today. So beta cell to brain to treat diversity is I'm going to discuss, and this means basically we would be having therapeutic potential approach and ways to manipulate brain neural pathways from beta cell signaling, insulin signaling, and other things. So we're going to manipulate. Can we manipulate brain neural pathways? Yes, we can. And it is basically teaching the brain for better metabolic control. Now, we generally say brain controls everything, but brain is also controlled by so many other signals, and we're going to manipulate and modify those signals. And we already know that gut microbiota is another, the second genome also controls the brain. So diabetes is already, a pandemic world over. We already know it. As per ICMR INDIAB study, which was published in Lancet 2023 from India, in all the states, overall, prevalence of diabetes is 16.4%, very high. And pre-diabetes 15.4%, urban, little less in rural areas. Similarly, generalized obesity is around 40%, and then we can see overall it's so around 30 to 40% is the prevalence of diabetes and obesity. So diabetes and obesity, they coexist. Now, obesity is skyrocketing, and like 50% of world's population would be having obesity by 2030. 50%, imagine. And if we see today, India is number 3. We used to talk of, so states, United States is still number 1 in having maximum number of obese people, followed by China and then India. And maybe, in times to come, we might supersede these two countries also. So diabesity is very important. There is inflammation, there is lipotoxicity, glucotoxicity, insulin resistance, inflammation. And there's altered brain signaling whenever there's a diabesity, and that is there's a impaired leptin and insulin signaling. So this is important, and can we normalize this? Yes. So normalization of impaired insulin, leptin, and other peptide signaling is our aim, which is altered in diversity. But the challenges are there's a complexity. It is not just one. There's a genetic, environmental, lifestyle. So many things are there. So we can't target one. We have to get everything in line. Then limited efficacy of the present treatment. We are failing in treating diabetes. Only 25%, 26% patients on treatment have A1C less than 7. Only 25%. So 75% or more still are having A1C more than 7% on treatment, I'm talking. What to talk of obesity? Obesity is now recent, therapeutic target after A1C. So we are failing in managing both glucotoxicity, means diabetes, as well as obesity. So we need to have treatment, sorry, which can target both together. So we need to have integrated approaches where metabolic and neurological factors both are taken into consideration. And neural pathways are very, very complex, very, very complex. So that also is to be seen. So nanoparticles, viral vectors are already there in the trials. Now, to regulate appetite or energy balance, hypothalamus is the key endocrine, organ which is there in the brain. And this, along with brainstem and limbic system, modulate feeding behavior and metabolism. So we have to target hypothalamus with efferent pathways through vagus and then efferent pathways down the line. And the nuclei which are involved are arcuate nucleus, ventromedial nucleus, and then amygdala. So overall, basically, we have to teach the brain and improve and normalize insulin signaling. And basically, like leptin, gut hormones, cholecystokinin, peptide YY, pancreatic polypeptide, GLP-1 is already there. We have GLP-1 with GIP with triple is also now going to come, retatrutide. Then endocannabinoid system can also be used. So overall, the many things which can be done to teach the brain to regulate metabolism as well as weight and the feeding behavior. So restoration of brain signaling is regarded as a promising way to treat diversity. So we have to restore whatever is impaired. Now, regulation of brain signaling is basically regulated by one is insulin, as I mentioned before, then IGF-1, leptin, neuropeptides, monoamines, and neurotropic factors. So all these have to be, used in different manner to have an improvement in brain signaling. Then even transport, like, you must be knowing that insulin, in type 2 diabetes, there's hyperinsulinemia. Despite of hyperinsulinemia, there is a diabetes hyperglycemia because of insulin resistance. So same happens. There are increased insulin levels, but these insulin levels cannot cross blood-brain barrier because of resistance, and less insulin reaches the brain. So in brain also there's an insulin resistance, and it is type 3 diabetes. So Alzheimer's patients who do not have diabetes are potentially, risk for developing diabetes later on. So that's a type 3 diabetes. So how can we, restore these? Basically, one is insulin. If it is used intranasally, we have now going to Afrezza is going to come up. Even in India, Cipla is going to launch. So that's one way of normalization of insulin signaling of brain. Then PTP1 beta inhibitors, leptin along with amylin combination, dopamine signaling system. Bromocriptine was, yes, all these molecules have some side effects also, but ultimately we would be having some molecule with least side effects and better outcome. Then serotonin is again very important for feeding behavior, sleep, and mood. Once we normalize this, like fluoxetine, which is SSRI, it improves feeding behavior and energy expenditure. Then melanocortin signaling system is another important, it plays an important role in insulin sensitivity, feeding behavior, and lipid metabolism. Blocking melanocortin 4 receptor, we have, selective MC4R agonist, which can act on these receptors, and that will help in improving feeding behavior and controlling energy expenditure. The neuroinflammation is another aspect, and molecules, like, because whenever there's an inflammation, there is release of TNF alpha, interleukin 6, interleukin 1. So all these again, have to be tackled, and once we tackle this, there would be improvement in brain signaling. So there are more approaches I would be telling which improve brain signaling, and these are certain hormones and neuromediators. Like intranasal, I've already mentioned, analogs of leptin, SSRIs, intranasal, even serotonin is also in experimental stages. DA2, dopamine, receptor agonist, bromocriptine was already there in the market, but because of the side effects, it was withdrawn. Then basically neuromediators analogs, DPP4 also play some role, and then administration of leptin with insulin, amylin, cholecystokinin, GLP-1. All these molecules have shown to modulate and improve brain signaling. GLP-1 receptor, one thing I will say, that what we know of GLP-1 receptor is that the decreased appetite and basically, suppression of glucagon, delay in gastric emptying. Most of the time, when GLP-1 is released, it gets metabolized within 1 or 2 minutes. So very less effect comes from there. 40% of this or 30% goes to the portal circulation. This stimulates through vagus brain, and 10% enters the systemic circulation through blood, and that enters the blood-brain barrier, goes to the brain, and this has the most pronounced effect. So the GLP-1 analogs which can cross blood-brain barrier have better effect on control of weight than other GLP-1 which cannot cross. That is why dulaglutide did not have much reduction in weight compared to liraglutide, compared to semaglutide. So basically this 10% has more pronounced effect on gastric emptying and decrease in appetite. So overall, see, so many GLP-1 are the molecules of today and the future. It is not what we know is diabetes. See here, kidneys, muscles, liver, cancer suppression, healthy aging, obesity control, adipose tissue, CNS neuroprotection, and vascular health. So GLP-1, like, you know, last decade we used to say is was SGLT2 inhibitor. Now it is GLP-1 in times to come. As a single GLP-1 or GLP-1 with GIP or with glucagon receptor agonist. Triple retatrutide is again undergoing trials. Now, other point is besides GLP-1, gut-brain axis. Gut-brain axis means brain, gut, and microbiota, all three. And all three have, say reversible control on each other. Gut and microbiota have on each other, microbiota and brain on the rest. Okay. So, as I mentioned, gut microbiota is the second genome, is more important. Top side down, brain down, gut up. And microbiota is controlling. The trials are there and it has been seen. Healthy obese people, there is dysbiosis. And if we normalize this gut microbiota, there would be reduction in the weight, normalization of weight. So dysbiosis has to be controlled. So gut brain, like as I told you, there is a reversible control of all three: CNS, microbiota, and gut. All three have on each other. Microbiota through metabolites, and gut through enteric nervous system and vagal, and then central nervous system also on both. And there are many trials that gut microbiome on diabetes, and these are certain species which increase and certain beneficial which decrease glucose control. So overall we can see this is normal. Here we have more of bacteroids, more of bacteria, and here is more of Firmicutes, gram negative. So harmful bacteria replace the beneficial bacteria. When we are born, the gut is sterile, and by 1 year the gut gets stabilized into a healthy microbiota at 1 year. After that, depending on what we eat, what we are fed, it creates dysbiosis. So healthy microbiota is getting replaced with the harmful one, and you develop metabolic. So we can control there and then, and that can be done with the use of probiotic. Even natural food, we have so many organic foods, yogurt. So it can be done through normal diet to replace, and then FMT, fecal matter transplantation. So overall, to target diabetes, a gut microbiota also plays important role. So current and future. Basically, there is the future is basically we need to understand the complex interaction between brain, pancreas, adipose tissue, and exploring the ways to stimulate specific brain regions to improve insulin sensitivity and to regulate eating behavior and food intake. So that can be done through neuromodulation. Animal studies have already, the trials are already going on different strategies to modulate brain. Then development of drugs which target both brain and pancreas, like GLP-1 is one, So similarly, more drugs we need which target both together. Then neuroprotective effect of insulin. Brain does not, utilize insulin directly. So we have to improve insulin signaling, which is impaired in diabetes. So this is the conclusion that effective treatment for diabetes must target both metabolic and neurological pathways. What we do today is only metabolic. So we need to even address the neurological pathways. Then we have to understand the brain's role in diversity, energy expenditure, eating behavior, mood disorders. So there has to be a collaboration in endocrinology, neurology, and molecular biology. Sorry, will be the key in developing innovative treatment for diabetes. So with this, I conclude and I convey my thanks to everyone.